A case which is on endovascular repair of a thrombus-laden pseudoaneurysm of carotid artery. Now, this is the story of a 78-year-old gentleman who had recurrent TIA in the territory of the middle cerebral artery. He had bypass surgery in the past, had left carotid endarterectomy 6 years prior to the admission. And he's diabetic, hypertensive, and has a very severe chronic pulmonary obstructive disease. So it's high risk for a repeat surgery. This is the angiogram, which shows a large pseudoaneurysm of the internal carotid artery and the common carotid artery. The external carotid actually originates from this pseudoaneurysm. This is the CT angiogram, which shows the same findings. And this aneurysm is, if you see the duplex scan, we find that the lumen is very small, and most of the aneurysm here is actually filled with a thrombus, a loose thrombus. Now, this is a thrombus on a B-mode imaging. So obviously, our surgeons didn't want to operate, and the redo surgery was difficult because it was extending high in the neck, and there was a loose thrombus occupying more than 90% of the lumen. The interventional, it was referred to us for intervention. The challenges were an acute takeoff of the left common carotid artery, a loose thrombus in the pseudoaneurysm. We had a choice of embolic protection device. That time we did not have a MoMA device, so we were left with the proximal protection, which was a Parodi system. We didn't have it, unfortunately, at that time. Or we could have done a distal EPI filter or an angioguard or a spider filter. And then there was a choice of stent. So what we did is, we cannulated the left common carotid artery. Then we passed in a guide wire, and on the guide wire and the diagnostic catheter, we could slide in an arrow sheath. And once we were at the distal part of the common carotid artery, we got good angiograms. We chose spider filter because it has the lowest crossing profile among all the distal protection devices. It is a 300 centimeter system, so we can exchange and do our entire procedure on this. It allows the use of coronary wires, and it has a very low incidence of spasm. And the pore size is 100 microns, so this was best suited for our sort of patient. So this is the filter going in. So once we were there, we opened the filter, and after that, once we confirmed the right positioning of the filter, we placed a fluency stent graft, which is a covered stent graft from Bard. And then we opened the stent graft by pulling back the sheath. And after opening the stent graft, we could see that the thrombus trapped in the filter here. Then we did thromboaspiration, and then took out the entire assembly of distal protection device. And this was the intracerebral angiogram, shows there was no distal embolization. The patient did not have any problem. And this was a follow-up CT scan after about 6 months. The stent was well in place, and there was no deformity or kinking of the stent. The patient was discharged on the 3rd day. He was on aspirin, clopidogrel, low molecular weight heparin, and ACE inhibitors, and there was no stroke or TIA. Thank you.
Did you get the thrombus in there?
Yeah, we saw. I showed you. We got a thrombus which was trapped in the filter. Today, if I have to do this device, I'll probably use the proximal protection. But the only problem is that the external carotid arises from the aneurysm, and there is a thrombus there. It will require much more of a manipulation. So at that time, we had an API filter and a spider filter. We thought that was the best thing, and we could actually suck a lot of thrombus with the guiding catheter itself.
It's a good case for multi-layer.
Yes, it is. But with a thrombus, I don't know.
No, no,
It doesn't affect.
no.
Okay, are there any further questions? Yeah, I think there are some questions. And somebody pass on the microphone to, and
Yes,
we'll have the
Dr.
lights
Bedi.
on, please.
That's an excellent management of a very difficult problem. One comment and a question. The comment is that it's actually not a difficult case for surgery. If you look at it carefully, it's not, but that's beside the point. Question is, was obviously a patch was used. So was it a vein patch or was it a Dacron patch? Because there are conflicting reports. Some say the vein patch has a higher incidence of aneurysm versus Dacron. So did you know what patch was used?
I think it was a Dacron patch because the patient was operated in escorts and most of the time it's a Dacron patch which they use.
Okay, thank you.